Everyone seems to be talking about dry eye these days. Articles, lectures, new companies, new products, new reps in our offices, and movie stars are all sharing how dry eye is all around us. As we've always stated, dry eye is a multifactorial disease that affects more than one portion of the eye and rarely has only one mechanism of action. In addition to others, meibomian gland dysfunction and inflammation play pivotal roles and oftentimes do so concomitantly. When doing dry eye management, we have to focus our efforts to treat both of these conditions. As we've stated in our prior episodes, we feel that the literature as well as our own personal clinical experience points to LipiFlow as being the most effective method for taking glands from less flow to more flow. But what about eyes that have become inflamed because of dryness? Historically, our thought pointed to steroids to quell this response, and although we would see improvement, it was short-lived. Instead, we believe that patients who have dry eye disease have a chronic and progressive condition predicated by a cycle of inflammatory tear production. It's as if there's a localized autoimmune type of condition where the lacrimal gland continually bombards itself, and tears that are saturated with cytokines are the result. An evaluation by Rao looked at a group of patients taking Restasis versus Refresh Endura over the course of 12 months. The study evaluated how many of the patients progressed in their severity levels. 32% of the patients taking the Refresh eye drops progressed in their severity levels by at least one level, while only 6% of the patients in the Restasis group progressed. We see this to mean that when left untreated or when treated with artificial tears alone, a pretty high percentage of patients will progress in their severity of dry eye. We believe that this is due to the chronic and progressive disruption of the lacrimal gland capabilities and the effect that it has on the ocular surface. As such, we have employed the help of several treatments in our office to manage inflammation in dry eye patients. First, anyone that we suspect to have or that we know has dry eye disease will end up on a long-term T-cell mediation eye drop. Although their proposed mechanism of action differ, both Xiidra and Restasis work to mediate cytokine release from the T cells and reduce the chronic barrage on the ocular surface and lacrimal glands. Depending on the level of inflammation present, patient symptoms, and damage to the ocular surface, our additional treatments will vary. If the patient has mild symptoms and only minor damage to the ocular surface, we'll just stay with the T-cell mediating drops. However, if they have more intense symptoms and or moderate signs of dry eye, we will use a steroid for 2 to 4 weeks. If the patient has more advanced corneal involvement, then we'll turn to amniotic membranes, preferably Procara, for 48 to 72 hours in an effort to bring about faster and more advanced healing to the cornea. These treatments are, of course, used in conjunction with our treatment of the meibomian glands. Over the years, we have seen this stepwise approach work to bring about a faster resolution of issues in our dry eye patients. The use of a T-cell mediated drop is critical, however, to ensure that there is a long-term plan for what we believe to be a localized autoimmune attack. Without a strong start and proper patient education, compliance may be compromised. With a detailed explanation and a long-term treatment strategy, we know that we can improve patients' quality of life, and that is why we do what we do.